Hi everyone, our subject today is precocious puberty in male. Basics. Precocious puberty in the male is defined as a beginning of secondary sexual characteristics before the age of 9 years. Isosexual puberty with the characteristic male sexual features occur as a result of normal male sex steroid. Heterosexual development with the female characteristics like gynecomastia is due to female sex steroid. Early puberty is the isolated development of pubic or axillary hair. History of a growth pattern, chronological development of the secondary sex characteristics, exposure to exogenous sex steroid like creams, lotion, meats, anabolic steroids, and family history of ambiguous genitalia or early pubertal development may be helpful. History of CNS disease, head injury, or radiation may indicate central cause. Symptoms including behavioral or emotional changes, headache, and vision problems require further assessment. Skin changes such as caffeolate spot may indicate neurofibromatosis or McCune-Albright syndrome. Examination. In boys, testicular enlargement is the earliest sign of puberty. Genital examination include penile length and diameter and testicular volume, which is measured by orchiometer. Pubertal testes are more than 8 mm in volume or greater than 2.5 cm longest diameter. Sexual maturity rating, SMR or tenor staging of pubic hair and breast in cases of gynecomastia should be evaluated. Measuring testicular volume carefully narrows down the possibilities, thus reducing the cost and number of investigation and the time taken for establishing the etiology. Be careful to differentiate between true pubic hair, curly and short, and dark lingo hair, straight, long, fine. An extra light source may be helpful. How to approach to patient with precocious puberty in male after performing history and physical examination. Is it heterosexual, which is feminization like ambiguous genitalia or gynecomastia? It will be discussed in another lecture. If it is isosexual, patient need bone age. If it is normal bone age and growth, this is premature puberty. Investigation may be needed. 17-hydroxyprogesterone, testosterone, dihydroepiandrosterone, and suppressed gonadotropin, independent precocious puberty, peripheral precocious puberty, HCG, and testosterone. As we mentioned, if it is increased 17-hydroxyprogesterone, this could be congenital adrenal hyperplasia. If it is dihydroepiandrosterone elevated, normal or moderately increased, this is premature adrenarche or idiopathic puberty. If all of these three increased, the patient need imaging, abdominopelvic CT, differential diagnosis, Leydig cell tumor, adrenal tumor, exogenous androgen like anabolic steroid, and McCune-Albright syndrome. If testosterone increased, could be familial male limited precocious puberty, testostichosis, or if there is HCG secreting tumor in cases of increase in the secretion of this hormone. Patient need imaging study, differential diagnosis, CNS tumor, hepatoblastoma, hepatoma, mediastinal tumor. If the bone age is delayed bone age and growth, this is thyroid hypothyroidism. Patient need TSH and T4. This is prolonged untreated hypothyroidism. If it is advanced bone age, patient need basal LH and FSH gonadotropin releasing hormone stimulation test. If it is suppressed, as we mentioned, this is peripheral precocious puberty, and we mentioned this investigation and this investigation. If it is elevated LH, this is gonadotropin-dependent precocious puberty. This is central precocious puberty. Patient need brain MRI. If it is abnormal MRI, differential diagnosis, tumor, hematomas, structural malformation, CNS infection, trauma, radiation. If it is normal brain MRI, differential diagnosis, idiopathic precocious puberty, prolonged exposure to elevated sex steroid, Makuni-Albright syndrome, and late treatment of CAH. Normal pubertal development in boys, testicular enlargement, penile enlargement, pigmentation of the scrotum, all of these range from 9 years to 14 years. Pubic hair appearance from 11 years to 14 years. Acceleration of growth, 12 to 16 years. Axillary hair appearance from 12 to 16 years. Classification of sexual maturity rating, tenor stage in boys. Pubertal stage, stage 1, this is prepubertal, nothing significant. Prepubertal test is 1 to 3 millim in volume. There is no pubic hair and no axillary hair. Stage 2, testis size more than or equal to 4 millim in volume or 2 or more 2.5 cm in length. Early penile growth, scrotal skin thinning, and pink. Pubic hair, minimally pigmented hair at the base of penis. Axillary, few axillary hair. Stage 3, testis enlarged to 10 to 15 millim in volume or 3.3 to 4 cm in length. Penile grows in length. Scrotal thickening and pigmentation. Pubic hair, darker, coarser, and curled hair extending to mons pubis. Axillary, adult pattern. Stage 4, testis enlarged 15 to 20 ml in volume or 4 to 4.5 cm in length. Penis grow in breadth, glands increase in size. Pubic hair, thicker adult pattern of hair not yet extending to medial surface of the thigh. Stage 5, adult genitalia, testis 25 millim in volume or more than 4.5 cm in length. Pubic hair, adult distribution spreading to medial side of thighs. Top tips. Luteinizing hormone level in pooled serum sample is the best screening test for central precocious puberty. Gonadotropin releasing hormone stimulation test is confirmatory. An organic etiology is more likely in a young boy with the central precocious puberty, unlike an older girl where most investigations are likely to be normal. Untreated precocious puberty is associated with short final height. Central precocious puberty is idiopathic in 90% of girls but only 10% in boys. Hence, careful search for cause, including neurological imaging, is warranted in boys and girls less than 6 years of age. Genital maturation without testicular enlargement rule out central precocious puberty in boy. Gonadotropin releasing hormone analog is the treatment of choice for central precocious puberty. Hypothyroidism is the only condition which causes precocious puberty associated with the growth delay and retarded bone age. Puberty can easily be assessed by bone age. If bone age is within 1 year of chronological age, puberty either has not or has just started. Bone age within 2 years indicate the child is in a puberty. Precocious puberty may have adverse effect on social behavior and social development. Early growth spurt causes rapid bone maturation, resulting in early epiphyseal fusion and short stature. A growth acceleration and advanced bone age, rest X-ray, favor a true precocious puberty against peripheral precocious puberty. Be aware that children with the hypothalamic lesion may present with the diabetes insipidus, polydipsia, polyuria, hyperthermia, early obesity or loss of weight, or inappropriate crying or laughter. Full investigation, including imaging of the CNS and abdomen, should be carried out for all children with the precocious puberty who have progressive sign of puberty, are younger than 8 years of age, with the neurological sign, or if the diagnosis is uncertain. Hypothalamic hamartoma, ectopic tissue secreting pulses of gonadotropin releasing hormone, is the most common identifiable lesion causing precocious puberty. Examination of visual acuity, visual field, and eye fundi is essential. Central or gonadotropin-dependent precocious puberty is due to early activation of the hypothalamic pituitary gonadal axis. There is increased FSH and LH, acceleration of growth, testicular enlargement, and pubertal level of testosterone. The bone age is advanced beyond the height, age, and chronological age. Precocious puberty in males may be idiopathic, but up to 75% have underlying CNS abnormality. Therefore, imaging of the head, preferably by MRI, is imperative in addition to careful neurological and visual examination. Hypothalamic hamartoma are the most common brain lesion causing central precocious puberty and may be associated with seizure. Other CNS lesions causing central gonadotropin-dependent precocious puberty usually involve the hypothalamus. These include post-encephalitic scars, tuberculous meningitis, tuberculous sclerosis, severe head trauma, and hydrocephalus with or without associated myelomeningocele. Neoplasms causing precocious puberty include astrocytoma, ependymoma, and optic tract tumor, including optic glioma in children with neurofibromatosis type 1. Penile or hypothalamic germinomas can cause central precocious puberty by secreting a human chorionic gonadotropin, HCG, which stimulate the LH receptor in the Leydig cell of the testis. McCune-Albright syndrome is a rare disorder presenting with the peripheral precocious puberty, caveolate skin pigmentation, and fibrous dysplasia of bone. It is more common in girls. When it presents in boys, there may be overproduction of androgen, resulting in acceleration, growth, and skeletal maturation. Prolonged exposure to elevated level of sex steroid may cause accelerated growth and skeletal maturation. Although the precocious puberty is typically peripheral gonadotropin independent, a secretory central gonadotropin dependent component may develop, also because of prolonged exposure to sex steroid. This secondary central precocious puberty may also be seen in late treatment of congenital adrenal hyperplasia. If the FSH and LH level are prepubertal and testosterone level are elevated to pubertal level, beta HCG should be checked. This hormone acts like LH, stimulates the testes to produce testosterone. Tumors producing beta HCG may be hepatoma, hepatoblastoma, teratoma, and chorioepithelioma. Prolonged untreated hypothyroidism may cause precocious puberty, in which cases the bone age is delayed. TSH level are elevated and prolactin level are mildly elevated. Although serum FSH is low and LH is undetectable, the elevated TSH appears to stimulate the FSH receptor, with no corresponding LH effect. Unlike in central precocious puberty, testicular enlargement occurs without increase in testosterone. Thus, the precocious puberty associated with hypothyroidism behaves as an incomplete form of central precocious puberty. In autosomal dominant familial male limited precocious puberty, testosterone beta HCG level are normal and testosterone is elevated. There is autonomous production of testosterone from premature Leydig cell maturation. Signs of puberty appear by age 2 to 3, and there is enlargement of the testes. Elevated testosterone level, particularly with the asymmetric enlargement of one testis, may indicate a Leydig cell adenoma. Another source of androgen is an adrenal tumor. Elevation of dihydroepiandrosterone sulfate above 700 mg per deciliter or testosterone above 200 nanogram per deciliter warrant imaging for adrenal tumor. Adrenal tumor are also associated with the increased DHEA and adrenostenone. Testosterone may be increased owing to production by the tumor or by peripheral conversion. Congenital adrenal hyperplasia is screened for by an early morning 17-hydroxyprogesterone level. Level below 200 nanogram are normal. Level above 800 nanogram are diagnostic of 21-hydroxylase deficiency, which is the most common form of congenital adrenal hyperplasia. Deficiency of 3-beta-hydroxysteroid dehydrogenase may result in precocious pupiarchy. Premature pupiarchy is most commonly due to premature adrenarchy when there is an early increase in adrenal androgen. Testosterone and gonadotropin level are pre-pubertal and DHEAs may be moderately elevated but appropriate for stage 2 pubic hair. The 17-hydroxyprogesterone level may be considered to rule out late-onset congenital adrenal hyperplasia. Significantly elevated DHEAs or testosterone level may require imaging study to exclude a testicular or adrenal tumor. Clinical follow-up of premature adrenarchy at 3-month interval is usually adequate. Bone age is usually consistent with the chronological age. If it is advanced, additional laboratory tests may be indicated. Idiopathic premature pupiarchy may be due to hypersensitivity of sexual hair follicle to androgen, and androgen level are normal. Thank you for your listening.